So you've torn your meniscus. What do you do? Anytime we hear that something is torn, doesn't sound great, doesn't feel good to hear, but the good news is most meniscus tears do not require surgery. Of course, some instances that they do with really large tears or specifically bucket handle tears when there's a lot of locking of the knee, something you want to discuss with your doctor. But most of them don't require surgery. In fact, the outcomes comparing surgery, meniscectomy surgery to physical therapy, a year out, the outcomes are the same, and PT has less incidence of advanced arthritis onset. So if we keep that meniscus intact and rehab it, we tend to be a bit better off. So how do we go about rehabbing these things? Whenever we have our meniscus tear, you can have pain kind of in the middle of the knee. If we try the medial meniscus, is where you most commonly see the tears. You have pain here. Also behind the knee are the two biggest spots that kind of stand out as meniscus pain. You can also have just kind of diffuse pain with all of the swelling. That initial swelling of the knee tends to be a big pain driver for people. So trying to control swelling and make sure we're able to kind of pump some fluid through there, that goes a long way with symptom relief. From a hands-on treatment standpoint, we like to do a lot of soft tissue work around the adductors, the quads, the hamstrings. That usually feels really nice. Sometimes we'll do some dry needling. That'll also kind of stimulate that pumping effect. And then we want to work on joint mobility of the tibia, making sure the tibia can rotate nicely. If we're dealing with medial meniscus tears, making sure the tibia can internally rotate. So just some joint mobility work there. From a strengthening standpoint, we want to work on stability of the entire lower leg. So that can be a lot of single leg work, a lot of isometric work, some tempo work. We'll make sure that the hip muscles are nice and strong. We're trying to decrease rotational shear at the knee joint, and that's going to require us to have strong feet, strong ankles, and strong hip muscles. So we really focus on that. And then we gradually work on increasing impact and loading of the knee. So some step downs, squat variations, lunge variations, but we have to progress these based on patient symptoms, how quickly those are progressing, and see what you can tolerate. But if we do that over a period of time, as symptoms come down, we can build our strength back up and we get back to 100% no problem.